But as we talk about writing an exercise prescription for osteoarthritis of the knee, is it that simple? I'd like to make some comments about what I found in studying this. I don't have any disclosures, but I will tell you a bias. My personal experience was that leading up into 2011, I was a very active competitive runner. And in fact, I just won two medals in an big international masters track and field. I just set the state record for the 1,500 meters in the North Carolina for 60-year-olds, having run under 5 minutes for the 1,500 meters at age 61. And then I got prostate cancer. Well, with prostate cancer, when you have to have surgery, for the first 12 weeks after that, the only exercise you can do is really pretty moderate. I mean, you do a lot of abdominal exercise. I did walking, some biking, but it was nothing like I was used to doing every day. 12 weeks of the date after having gone in before that prostate surgery, racing, running 30 miles a week and racing regularly, when I came out of the prostate surgery after 12 weeks, if I walked 800 meters, I would have effusions on both knees. Now, I'm sure my knees were the same before and when I went out. I would have effusions on both knees. I would have substantial pain. If I played one set of tennis, where now I'll often play 5 or 6 sets of tennis, I would have effusions on both knees. So I went on a very intense exercise program to see if I could turn that around, and it made a tremendous difference. In fact, I walk 5 to 10K every day, and I play 8 to 10 hours of competitive tennis, mostly singles, every week. And that's with the same knees you just saw. So I have a bias that I think exercise helps. Unfortunately, if you look at exercise, it's not going to help forever if you have bad knees or a bad hip or whatever. So for some goals and objectives, I'd first like to review some of the evidence-based medicine that supports an exercise prescription, and I can tell you that's pretty strong. I would like to also help you understand maybe some appropriate types of exercise that might help you maintain fitness and help your patients who, like me, may still consider themselves an athlete but need some help in an exercise program to deal with their arthritis. Thirdly, discuss the balance between weight-bearing and non-weight-bearing exercise in knee OA, because I think this has actually been done wrong over a lot of years, as we thought that only non-weight-bearing was best for osteoarthritis of the knee, but I would challenge that. And then describe a process to monitor this clinically. So is exercise good for knee OA? We should ask that question first. In the last August, the edition of BJSM has 2 meta-analyses that look at this and also for general arthritis, and they both came to the conclusion that it's quite good. And their conclusions were the same as this Cochrane review, which is also relatively recent. And they abstracted data from 54 randomized controlled trials, so not a small data set. And it was land-based exercise. Now, land-based exercise would include some open chain exercise, but a lot of it was weight-bearing. So land-based exercise, and they found high-quality evidence that land-based exercise reduced pain. And that after you quit that program, that pain reduction continued for 2 to 6 months. So that's a pretty effective sort of challenge. It did not persist for 1 to 2 years, though, and in none of the studies you will see that it persists for long term. What about other benefits? What about function? What about quality of life in the short term? Well, there was at least moderate quality evidence, also from trials that contained about 4,000 patients, that exercise improves physical function. And then there was high-quality evidence that it improved quality of life. And that may be what's most important to our patients. So I'd like to emphasize quality of life studies are quite important. All these studies are challenged by biases. Not all of them were done the same way. And you know that if you've looked at systematic reviews or meta-analysis, that they're hard to do. But I think the evidence, the preponderance evidence was so strong that this is either high or moderate quality. Well, what about aquatic exercise? Surely that's got to be better for you if you got osteoarthritis than all that land-based exercise. Well, interestingly enough, it really didn't prove to be so. In the studies that have looked at it, that are summarized well in the references, which I'll put at the end of these slides, there was only moderate quality evidence that aquatic exercise had a small and a short term. It was a clinically relevant benefit, but it's a small benefit on patient-reported pain, disability, and quality of life. If you did do group-based exercise in water for 1 year, some of the interesting changes with it were not only an improvement in the physical functions, but you also used less dollars for your health care. You had less visits to the doctor, you used less medicine, you had less follow-up x-rays, for example. So there was clearly some benefit in this. But why is it when we prescribe our patients, you need to go to the swimming pool, you need to do your exercise for your knee or hip, that it's a problem? Is that after 1 year, only 18% of the patients will continue using water therapy for their arthritis. So it may not be the patient's first choice. I don't think it's that the exercise fails. I think it's just not a logical choice for some people. There may be some specific type interventions that are kind of interesting to think of. Well, if they looked at one, for example, for years we've given people isometric exercise, tightening their quads, tightening their hip abductors, other things to try to help with this. But if you do, in one study at least, proprioceptive exercises where you do more one-foot balance, where you do some lean and reach and other things, you actually got more benefit from that than you did from an isometric exercise program. And then there's a full Cochrane review that looks at the difference between high-intensity exercise, because there's lots of studies that have come out recently that just a few minutes of high-intensity exercise may be as beneficial to your fitness level as doing a much longer workout of lower intensity exercise. So there's a lot of popularity of high intensity exercise, but Cochrane found low quality evidence that there's really no important difference between high intensity exercise and low intensity exercise. So the good news though is the high intensity exercise did not cause more pain or more injury. So it's not that you should prohibit it, it's just that it's not clear that it's more beneficial. What about strength exercises? If you have a patient, like I was at that time, who really needs to do something because their knee pain is quite severe, it turns out the strength exercise may be the best choice. A lot of those strength exercises are going to be open chain, as it turns out initially, and the second point was that the non-weight bearing strengthening exercise gave the greatest pain relief. So for example, when I came out after that surgery, I was on a series of doing somewhat about 400 to 500 leg lifts a day with varying levels of weight, working all the muscles that stabilize the knee. So I was using a wide variety of those, and it made a tremendous difference in pain. In fact, I was taking very little pain medicine, no more than 2 pills a day of something on most days in spite of the pain. So muscle strengthening exercise may be unique in those patients who have severe OA, grade 4 arthritis like I do, and is a good option for you to start. And it's almost counterintuitive. You see someone with a swollen, painful knee, and you send them home and say, you should exercise, or you send them to your physical therapist and say, we need to start you on exercise today. You have to explain that to your patients who say, my knee hurts, you're going to tell me to exercise on it? But you have to convince them that this is really going to relieve their pain. Well, should you maybe use a combination of exercise? And I thought this was a great paper kind of reviewing this. And what it did, the paper concluded, yes, there is a significant benefit of exercise over no exercise, but it's unclear that any one form of exercise is the most beneficial. So this trial looked at strength, flexibility, and aerobic exercise separately, each one of those, but each one of those caused a significant benefit. And then they looked at combinations. They used strength and flexibility, strength and aerobic exercise. They used all 3 of them together, or any 2 of them together. And it turned out that all combinations caused significant benefit in pain relief, function, and quality of life for patients as well. So the expert opinion from the authors in this paper, not the evidence, their expert opinion was it makes the most sense probably to combine types of exercise. Give people some flexibility, give them some strength, and give them some aerobic conditioning as part of their overall program. But remember, this was only studied primarily for knee arthritis, so I can't tell you if it applies to hip as well. So my choice when I got through my surgery was cycling. I would cycle 20 to 30K every day, and I felt clearly it made a major difference, so I was particularly interested in looking at the cycling data. And this is a 12-week intervention in a group with stationary cycling. This was mild to moderate knee OA, and they showed significant improvements in multiple parameters. Particularly, they walked at a faster pace. They had less pain when it was tested. Their WOMAC scores were better. Their KOOS scores were better. So cycling clearly seems to make a difference. And in my patients, honestly, cycling has become the preferred exercise that they would like with knee OA. And I think if they have trouble on an upright cycle, it's good to try a semi-recumbent one if they do that. Well, do you need high-intensity cycling? That was also tested in cycling, and they saw absolutely no difference in cyclists who used a high intensity versus a low intensity. So a lot of my patients come in and say, well, this won't do me any good unless I rev this up to a resistance level of 5, 6, or 7, and I tell them no. It may even be the motion you're doing with cycling and the light stress that it puts on the quadriceps that's a big difference. So low intensity versus high intensity made no difference in the cycling groups. So the nice feature of that, again, though, is that the high-intensity cycling did not increase the pain levels. So if your patients do like high-intensity exercise, don't discourage them from it. So how do you monitor your exercise programs? And I noticed in the Exercises Medicine Clinic here that they were using a KOOS survey, other things, and I think those are good. There are numerous osteoarthritis monitoring scales. WOMAC has scales for pain, function, and stiffness, for example. There's an arthritis impact measurement scale, their quality of life test. There's a sit up and walk, and there's a timed walk sort of test you can use, and just basic strength testing. All those are valuable tests, but I would argue as a clinician that those help me more when I'm doing a research study. We're just doing a research study actually on knee OA, looking at compression versus bracing versus standard physical therapy and combinations of those. So what we do in our clinic is we do a very clinically focused follow-up. We look at medication use. I tell my patients each time, I'm going to ask you, how much medication are you using for pain from this visit to the last? And what you see with the exercise program is you should be seeing a steady reduction if you've got a good exercise program. And then I look at nocturnal pain. Are you waking up twice a week with your knee pain? Once a week? 5 days a week? If they're waking up frequently, you need to make a change. I look at their walking distance. How far do they walk before they have the onset of pain? If it's continually getting further, I think I'm making progress. I always ask that baseline pain level, and I notice that you do that here. I think that's a good thing to do. You do your standard clinical testing, particularly for range of motion, but strength. I like to look at 1 foot balance, and are they able to get up out of a chair without using their hands, other things like that. And then we've started using ultrasound for effusion, and I was trained that osteoarthritis was a dry arthritis of the knee. But in active older adults in our clinic, over 50% of the patients with knee osteoarthritis have an effusion. We also did a study that we reported last year following experienced orthopedists, getting them to estimate whether they had effusions or not. They're wrong about half the time in athletic patients, based on our ultrasound findings. So we're not as good at detecting effusion by physical exam as we think we are. There's a lot of effusions out there in older patients. And this is where we think, when we're doing the study on compression, we think the compression may make a difference in reducing those effusions. That's what we're hoping to find as we do this study. So in summary then, I'll finish up to say that exercise treatment for knee osteoarthritis, there's very good evidence-based medicine that you should prescribe exercise for knee OA. I think we have that established. There's good evidence-based medicine that suggests that strength, aerobic activities, and flexibility activities are all helpful. So you can choose one of those, all of those, or a combination of those. There is no evidence-based medicine that suggests you need to do high-intensity exercise. You can do either high or low intensity. And the frequency of exercise has not been established. But most of the studies use 3 to 4 days a week, and so that's what we've usually relied on. In final summary, weight-bearing and non-weight-bearing exercise both can be used, or you can use combinations of each, which is what most of my patients will do. And patient compliance, this is the shared decision-making. Talk to your patient. None of the exercises we give them are going to make a daggone bit of difference unless they're willing to do them at home. They can't go to physical therapy often enough that it's going to make a lifetime of difference. So we need to get them established on a home exercise program. Monitoring, I think you can do it primarily clinically. You don't need special tools for that. And strength gain or maintenance is essential for pain relief and function. And in the studies that have looked at strength, they did find that it didn't take but 6 weeks of exercise to start seeing a difference in the strength of those patients with knee osteoarthritis once they were started on a physical therapy program. Thank you very much. The references are at the end of this talk.